Hi, my name is Rebecca Hancock, and I am the Patient Safety and Quality Advisor at the Indiana Hospital Association. Today we're featuring Dr. Brian Wagers to help us understand the recognition of pediatric sepsis in the state of Indiana. And Dr. Wagers is the Physician Director of Pediatric and Maternal Quality and Safety at Riley Hospital for Children and an Assistant Professor of Clinical Emergency Medicine and Pediatrics at Indiana University School of Medicine. We're privileged to have him sharing his knowledge with us about pediatric sepsis recognition today. Dr. Wagers?
Rebecca, thanks for having me on to talk about what is really a big problem that all of us struggle with, but hopefully when we finish today we'll have some tools and some strategies that can help us to recognize those children that come into our various emergency departments and hospitals with sepsis. So, and that's where I'm actually going to start, is just kind of talking about the problem. Sepsis is a big problem, not only in the United States, but worldwide. For instance, worldwide, sepsis is really the #1 killer of children. When you talk about all the different types of sepsis that there could be, and focusing in on the United States, here, every year, we have around 75,000 children who contract sepsis of one form or another. And that averages out to about 200 children per day. And that number is increasing. And it's increasing at a rate of about 8% every single year. Now, how does this translate into the big effects of sepsis, which that being mortality? About 7,000 children die from sepsis every single year. And to put that in a bit of perspective, that's more than actually die from pediatric cancers. And we have a lot of recognition, a lot of resources that go to treating pediatric cancer, and rightly so, but this just demonstrates how much of an even bigger problem sepsis is and why it's a good mission for all of us to be on to combat sepsis and try to recognize it better, as well as one of my colleagues will talk about a bit later, that being the treatment of sepsis. And sepsis is a quick killer. About 50% of children who contract sepsis and go on to die from that, they'll die within about 24 hours of their diagnosis. So it's one of those things that early recognition is key, because we can start those treatment modalities sooner and hopefully lead to better outcomes for our patients, which is why we all do what we do every single day. Of those 75,000 kids that do contract sepsis each year, 34% of those kids who survive their sepsis episode will go on to have cognitive difficulties. So that leads to a large burden in terms of our school populations, as well as just the overall well-being and productivity of future members of our society. And about 47% of kids who have sepsis will then be readmitted at least one time for complications of their episode of sepsis and their underlying illness. So I think that's a decent job of outlining what kind of a problem it is and what we're facing here in America in particular. Let's move on now to the nitty-gritty, and that being the recognition of pediatric sepsis. And first off, I want to acknowledge, even doing this every single day as my clinical role, recognizing pediatric sepsis is tough, because the symptoms of sepsis mimic those of a host of other more benign illnesses. For instance, I mean, the symptoms that we want to look for, that being fever of 100.4 or greater, fast breathing, a fast heart rate, or a drop in urine output, my goodness, that's many of the children that come into our emergency departments, especially in the winter. So it really is trying to sort out who is truly sick in terms of being septic and who has another explanation for their symptoms. And I joke sometimes that seems to be about 90% of the kids that come into my emergency department in the winter that present with at least a couple of those symptoms that I just listed for you. But the good news is that there are ways to improve our recognition of sepsis, and I'm going to talk about one of those tools here and a group that did some excellent work regarding this topic in the next few minutes. And that group is the Pediatric Septic Shock Collaborative. This was a partnership that was between the American Academy of Pediatrics, particularly in the section of emergency medicine, as well as the Children's Hospital Association and nationwide. It initially started off with about 47 children's hospitals, and then by the time they got through the several-year process of data collection and development of the guidelines, it ended up being about 25 different children's hospitals that participated. And their goal from the beginning was to decrease the mortality in pediatric sepsis by 20% in their participating institutions. And I'm happy to say that they were successful in doing that. And in some institutions, by far more than just 20%. So let's move on to the tool. Now, this tool is available free of charge on the internet. If you simply Google the Pediatric Septic Shock Collaborative Trigger Tool, it will bring it up in PDF format. So I'm going to spend some time talking about this trigger tool. So when you're not listening to this podcast, go ahead and Google that, bring it up, and it'll bring all of this next few minutes to life for you. As I said, this group essentially did most of the work for us to help identify pediatric sepsis. Essentially what they did is they created an algorithm, a flow, for when patients are suspected to be ill that you can use to screen them for the presence of sepsis. And this simply takes into consideration many of the things that we already look at when we're looking at vital signs, et cetera, but also brings in a couple of unique aspects that we'll spend some time on discussing as well. Simply what they do is they look at the temperature of the patient, and that is in degrees Celsius, and they provide a table for you to look at normal ranges of temperature for ages. They do that for all of the vital signs. They look for hypotension, so the blood pressure, and again, they provide you with a vital sign chart based on age, which comes from the Pediatric Advanced Life Support literature. Because we all know that unfortunately what's tachycardic for a 1-month-old is certainly tachycardic for a 13-year-old, but the vice versa is not true. What is tachycardic for a 13-year-old is certainly not tachycardic for a 1-month-old. And that goes for the remainder of the vital signs in terms of the respiratory rate as well. So they've broken that down nicely for you. And I always like to have an aid, if I can, at the point where I'm looking at patients, because I think the more things that you can unload from your brain in the moment, the better. So references that are easily available are great. That way you don't have to memorize all of these numbers for yourself. The new and sort of, I use new loosely, but novel things they put into this assessment are the following. That's a capillary refill time, looking at the mental status for children, looking at and determining the quality of the pulses, as well as doing a full skin exam. I know a lot of people are hesitant to undress children, even in the emergency department. So this is really a big barrier, that if you aren't undressing your patients and putting them in a gown so that you can fully assess all of their skin, it's possible that you're going to miss pretty significant findings, including things like the patient being a bit mottled, or petechiae, or God forbid, purpura that are covered up by clothes. So I know we've had a few instances in our practice where, had we not undressed the children, we would have missed some of those key findings. So I would encourage you to undress children as part of your regular intake and evaluation process, just because that's key. And along with doing that, that allows you to get a good sense of their pulses as well as their capillary refill time. You can check that in a couple of different spots. And again, this trigger tool that I'm talking about has a chart for you that tells you what is normal and abnormal in terms of capillary refill time as well as pulses. I would expect most of us would know what those abnormal things are. The part that is particularly useful, I think, is when we get to the mental status assessment of patients. It's quite difficult to assess the mental status of a 6-month-old. Sometimes it's hard to do that on a 3-year-old as well, particularly when it's at a time of day that they're not used to being awake, or when they're already feeling ill, they can be quite irritable. And that's not necessarily an indication of sepsis, but this trigger tool does spell out for you ways to elucidate whether a child is abnormally irritable or crying in an inappropriate fashion, as opposed to just being fearful of the interaction or just not feeling well. It's important to note, too, that this trigger tool that they developed was meant to be quite specific. It's not meant to be sensitive. So there's always a balance between specificity and sensitivity. And this trigger tool is quite specific. So what do I mean by all of that? So that's a lot of jargon there, so kind of driving it home. What that means is that this tool, if a child screens positive for sepsis with this tool, you can be fairly confident that they actually have sepsis. But what that also means is there's going to be some kids that this tool is not going to pick up. So we always have to keep a high awareness and a lookout for kids who could potentially be septic that won't screen positive. And you'll know what I'm talking about when you look at the vital sign triggers on this. For instance, in a 1-month-old to a 3-month-old age range, their heart rate to trigger positive on this, they need to have a heart rate of greater than 205 and a respiratory rate greater than 60. So as we can all agree, I think those are quite abnormal. So there are going to be kids that still have sepsis that aren't picked up by this, and that's difficult, admittedly so. We have to have a high index of suspicion. And one of the ways that we can have a high index of suspicion, and if you take nothing else away from this entire talk, I would encourage you to write these down if you're at a spot where you can do that, or if you're listening in the car, when you get home, replay this section of the podcast and write these conditions down, because children that come in with the following list of conditions should make you have a high, I can't emphasize that enough, suspicion that they could potentially be septic, especially if they have fever. And those are kids that have a malignancy, kids that are asplenic, including those who have sickle cell disease, any child who has had a bone marrow transplant, a child who has a central or an indwelling line or a catheter, kids who have had a solid organ transplant, and this one is a big one, kids who have severe cognitive delays or cerebral palsy, also known as static encephalopathy, and any child that is immunodeficient, immunocompromised, or immunosuppressed. And that includes kids who are on steroids or other immunosuppressant medications for various conditions. When we looked at our data here at Riley, almost all of the kids who went on to have sepsis, of course not all, but a large percentage had one of those conditions that I just mentioned to you. So again, those conditions were malignancy, asplenia, including sickle cell, bone marrow transplant, central lines, solid organ transplants, severe cognitive delays or static encephalopathy, or any reason to be immunodeficient or suppressed or compromised. So with that, any child that walks in with one of those, please make sure that you're thinking about why they're not septic, not could they be septic, but make it be an opt-out sort of a thing, and that usually won't lead you down the wrong path. As far as going forward, I would like to say that we're perfect at children's hospitals. We're not, but by using this tool, we have been able to improve our sepsis recognition here with the ultimate goal of decreasing the morbidity and mortality that we see from such a high-risk condition as sepsis. So with that, I thank you very much for giving me your time today. And if you have any questions, of course, we're always willing to answer any of those. Just reach out through your normal channels.
Thank you, Dr. Wagers. That was excellent content. I think that the Pediatric Septic Shock Collaborative Trigger Tool is a new item in the literature that will be very helpful to our hospitals across the state. With this high incidence of sepsis cases of 75,000 per year, we have a lot of work to do. The high mortality associated with it. I'm interested in the fact, the specific vital signs and associated how difficult it is to determine if a pediatric patient has a low urinary output, along with the other vital signs, and just a consideration that we think about that as we assess our patients, and also the assessment of mental status when there's a suspected infection present, and the risk factors for sepsis in the pediatric population. As you mentioned, the very important risk factors for us to almost start with the fact that they are potentially septic, and that's where we need to start our assessment. This is excellent content, and I thank you very much, Dr. Wagers, for participating in our podcast today and sharing your knowledge.
Thank you very much again. Thanks for having me.